Good afternoon. My name is Charles and I'm coming to you from Singapore. And today I'm going to be sharing with you about AI in nuclear medicine. So in my role, I'm actually a senior consultant in nuclear medicine, but I also am the Chief Medical Informatics Officer for Singapore General Hospital. So that's my other role. And specifically today, I'm going to be talking about AI in nuclear medicine. So I think for, sorry, I just thought, it's not, okay. Yeah, this is a slide actually showing a large number of vendors that provide different AI applications and different models. This actually is taken from Carpel's website. And I think earlier on during the presentations, the previous sessions, the Korea meets Vietnam session, which was very interesting, I think they already mentioned that there are more than 1,000 AI applications that are approved by the FDA, the Food and Drug Administration of the US, out of which about 75%, more than 75% are actually in the radiology space. So I personally wonder, I don't know whether all of you can follow along as well. How many of you have AI in your centers? You're using AI now for clinical reporting. Okay, so we do have people using. My question always, you have so many models, how many are we actually using today? It's a real big question because I feel there's so many vendors, so many models, but we don't actually see a lot of AI applications that are being deployed, and in particular in the nuclear medicine space. So the European Association of Nuclear Medicine actually said that AI in nuclear medicine is lagging behind AI in radiology. Because the nuclear medicine side, they always assume that the radiology side will actually go ahead and implement the AI, and maybe, then we can implement in nuclear medicine. And if we think about nuclear medicine, we have a very similar process in terms of how we do diagnostic work, scanning. We do the ordering, scheduling, protocoling, the actual scanning, then we do post-processing, interpretation, and reporting. But we know that nuclear medicine isn't just about diagnosis. Nuclear medicine also includes therapy, and the therapeutic work goes all the way from radiopharmaceutical development to treatment planning, to the actual administration of therapy. And of course, we can't forget things like education and research, which goes across the entire diagnostic as well as therapeutic pathways. So I think in nuclear medicine, we can't afford to sit back and sit behind. Actually, we really need to be quite actively involved in looking at the different processes, especially where it's different from radiology, where there are areas of therapy. We actually need to be thinking about how we can develop clinical AI use cases and different models for the use in therapy and education where we are unique from radiology. So if you look at the entire space of both the diagnostic and therapeutic work, a lot of it there's overlap with radiology, and there are many, many different AI tools that have been developed. For example, in the ordering and scheduling space, there's clinical decision support. So are clinicians ordering the right scans? Do they even know what's the difference between FDG and dotapeptide? So there's clinical decision support that could come in. How about scheduling our patients? There's actually auto-scheduling that has been developed. For the protocoling, from the order to the what kind of scan and how we do it, there's the protocoling aspect that has AI applications. In the scanning process, when we are scanning patients, automated positioning and helping in the image acquisition. After we have acquired the scan, there's denoising, there's reconstruction algorithms that are enhanced by deep learning. And actually, I must say, one of the most popular areas for us to have AI is actually in the interpretation section. So image interpretation is a very big thing, and a lot of us focus on it, but it's only one small part of where AI can come in to our clinical practice. And in the area of interpretation, we have CAD-T, which is triage, there's CAD-D, detection, and computer-aided diagnosis as well. So there are many different things that we can even do before we even talk about being able to, for example, give a report or to give interpretation. There's many different processes that can be enhanced by AI. In terms of reporting, a lot of time is spent crafting and formatting reports. And that is something that large language models have increasingly been used for today. How about things like summarization? A lot of times when we write reports, they may be designed to be given to other medical practitioners, but patients often also need common language reports, which large language models could assist with today. And so the areas where we are different or slightly separate from radiology in terms of therapy, there's actually quite a lot of interest right now in radiopharmaceutical development using what we call in silico drug design, where AI is used to simulate and to select from different drug molecules so that we can actually increase the speed of drug development. While there hasn't been a use case or there hasn't been an example where it's been successfully done in radiopharmaceuticals today, but in terms of drug development, we have seen cases where I think there was one that was currently in the final stages for trials where they managed to shorten the drug development timeline from 15 years to just a single year. In terms of treatment planning, there's dosimetry. For therapy, our sort of engagement with patients, there's ambient documentation and protocol optimization. And finally, in the space of education, we can use large language models, especially with what we call retrieval augmented generation, to help us in educating our residents and our junior doctors. So today, I would like to just focus on some of the things that we have tried in Singapore, some of the things where it's been successful or we see that it's likely to be successful, and maybe some areas where we have had less success. Let me just put it that way. And I'll just share honestly about where we are right now in Singapore for AI in nuclear medicine. So one of the areas I think that has seen a lot of development over the years is denoising and image reconstruction. We see AI actually as just a continuation of the continual improvements in this space. In the early 1980s to 1990s, we had filtered back projection, which allowed us to get images of a certain quality. But in the 1990s, with the expectation maximization techniques, we actually see further improvement in image quality. And further in the 2000s, we have combinations of our expectation management and point spread function to get even better results. When we add in what we call a priori, which includes previous information and expectation management, as well as combination with MR, we can get further improvements in image quality for the same scan time and dose. Today, with deep learning, there are various methods that have been proposed and actually implemented, especially in the newer, a lot of them are actually packaged with the newer PET scanners that have come out. So we can do post-processing or denoising using neural networks, working on the image that has already been constructed using the other methods that we have sort of listed before. But there's increased interest in doing direct reconstruction from the source data, which can produce very good results with improved image quality, reduced imaging time, and reduced tracer dose. Combinations of both the expectation management and neural network techniques have also been proven to be quite interesting in practice. And so this is an image from a paper looking at different deep learning reconstruction methodologies for different levels of dose. So this is the original image on top, where we see what we should see with 100% dose. And these are actually images using a simulated reduction in dose count of 75%, 50, 25, and even as low as 1%. So in this paper, they were able to get clinically usable images at more than 90% dose reduction. So the images at 6.25% count using either UNet, which is a neural network-based methodology, and also SWIN IR, which is a transformer-based, they were able to get clinically usable images with a dose of as low as 6.25%. However, when they continued to reduce the dose that they put into the algorithm, we started to get certain artifacts. So for example, here there's a blow-up of a imaging artifact of fake or artifactual increase in FDG uptake in this area in the liver. And similarly, in the transformer method, we also saw imaging artifacts at very low doses. So we know that actually while we can push the envelope to get much lower doses, there's probably a limitation. And for clinical applications, a lot of the newer scanners that are being released today, they are able to achieve similar image quality with up to 50% dose reduction. And this is something that we are already seeing in clinical practice today, and certainly is one of the main applications I would see in terms of AI enhancing the practice of nuclear medicine today. In our own experience as well, we wanted to see how AI could help us in terms of our imaging interpretation. And there was a fairly recently published paper on total metabolic tumor volume automated assessment. So we looked at, this was published in EGNMI, and we wanted to see whether we could use it in our own setting. So actually we tried it, because a lot of times when we see publications which have very good results like this one, these were the results that they published in EGNMI, so showing us how the green is the physician assessed segmentation for these FDG PET scans, and here in a sort of a pinkish color is what the AI-based segmentation was able to achieve. The DICE scores actually describe the area of overlap, so how much overlap there is between the physician segmented and the AI segmented. So obviously higher is better, and from a range of 0.6 up to 0.8 or higher is considered fairly good agreement. They also had the clinicians assess how good the performance of the AI was, and you can see that in some cases, despite a fairly reasonable DICE score, the clinicians actually still assessed that the AI image segmentator didn't perform well. I think we can see, for example, in this case where entirely missed area of nodal involvement in the mediastinum actually was not picked up by the AI segmenter, but was picked up by the human segmenter. It tends to underperform in areas where the amount of uptake in the nodes is not very high, or where sometimes, in this case, for example, it maybe is closer to areas of normal activity. So you can see here that the human segmenter was able to pick these up, but the AI was not. So looking at the results that were published, we attempted to use the same model in our own setting, and we did a local validation with about 65 PET scans, and while the overall performance, if you just look at the DICE score, looks very good at 0.78, and it was able to exclude a lot of the physiological sites such as plug site, muscle tension, etc., but it did have difficulty with certain large lesions, and it had blind spots in the marrow and spleen. So these are two fairly well-segmented examples of lymphoma in these patients. We see that the automated segmentation performs fairly well and requires quite little adjustment by our human readers. However, when we looked at other cases, we found some slightly bizarre results, which I think is something that we need to take very good care of when we're using AI applications. As mentioned earlier, bone marrow lesions as well as splenic, for example, in this case, the spleen had increased uptake and was larger. They are actually missed by this AI. But some of the really unusual things that we found quite strange, if you see the segmentation here for this lesion, misses almost half of it. And sometimes when the AI models fail, they actually fail in ways that human readers do not. And this is actually one of the areas I feel we have a really strong role to play. The good thing is that because this is an AI segmentation model, after the AI segmenter has done the segmentation, the humans can actually add on and segment it properly and add on the other areas which were missed. I think we will continue to see a need for a combination of AI pre-work and human sort of add-ons after that. Another area where we have already implemented, and this was actually part of an enhancement to an existing product we were already using, which was MIM. We do dosimetric calculations using segmentation. Previously, these were all manually drawn, and now with automated segmentation using deep learning, our technologists are able to save about an hour per case, and it also helps us to do automated dose calculations. So that's another area of success in terms of AI applications that we have clinically implemented. I think right now one of the largest, most interesting topics is large language models. And to help us actually implement large language models within healthcare, our public healthcare network actually has 2 models that have been developed by our local IT sort of vendor support. They're called Pair and Tandem. And one of them was developed in collaboration with Microsoft as well. When we introduced these large language models, not the commercially available ChatGPT, but one that works within our secure hospital network, a lot of our staff actually can work on them directly to develop many different use cases for it. I think one of the areas that has seen a lot of success in terms of large language model deployment locally in our hospital is what we call retrieval augmented generation, where we put in policies, for example, our imaging guidelines and policies, contrast policies, etc. And then we allow, for example, our clinicians to use the large language models to query these. We have seen great success across multiple different use cases, for example, finance policies, HR policies. This is a very low-hanging fruit, and I think most centers will be able to implement this quite easily nowadays. In terms of more specific use cases to nuclear medicine and radiology, report summarization, formatting are certainly things that we have explored, and I'll show you one of the cases that we have done recently. Education, for example, the drafting of questions based on, for example, the American Thyroid Association guidelines. So all of them need to be grounded in fact. We will usually feed them with specific databases of information. And finally, in terms of note-taking and documentation. So I'll just quickly show, this was something that we explored together with our medical oncology colleagues, how we can do report summarization for lymphoma. So right now our lymphoma reports, this is actually probably our fault. It's not very well structured in that sense. It's a little bit more of a free text or prose. But what we were trying to explore is whether large language models could be used to extract particular features. So in this case, we are looking at the Deauville score, the sites of disease, the FDG uptake in terms of SUV max, the dimensions, size, and whether or not they are resolved. But we also wanted to do staging. And we found that it was quite good at extracting very standardized things like Deauville score, and actually was able to extract a lot of the measurements fairly well. Where it sometimes faltered was in terms of the sites of disease and staging. Okay, I'm not going to go over this because it's very messy, but I'll just say that this is our original report. You can see, you can barely see the text. There's a lot of text. And what we did was we did a 2-stage model. The first model is we fed it into a large language model called Claude, and then we did the initial part of the summarization. And then after that, we used GPT-4 to then do the staging. And we are finding that chaining LLMs actually may give us better results than using a single LLM. These kind of reports right now, we have achieved accuracy of more than 90%. The problem is that this may not be applicable for clinical use yet. Our medical oncologist is very concerned that if we don't get 100%, we can't use it for clinical, but we are using it right now for research as we continue to try to push the accuracy higher. Very quickly, I'll just say that we have implemented using a large language model-based methodology of collecting clinical dialogues. So when we have consultation with our patients, we can use a microphone, record it down. In Singapore, we have many cultures, so it actually takes in English, Mandarin, Malay, Tamil, and Cantonese, and it can help us to do summarization into a very structured manner. Since we introduced this last year, we have about 3,000, almost 3,000 users and more than 30,000 notes that have been summarized. I know we don't have a lot of time, but I'll say that actually it didn't save very much time in terms of documentation, but in terms of better patient experience, there's more eye contact, the clinicians don't have to be typing all the time, the notes are summarized. Very quickly, this is a verbatim transcript on the left, and here is the summary that we produce. You can see that the patients can go in between English and Mandarin, which happens very commonly in Singapore. But on the right side, it's all formatted nicely for us, and this is something we are actually using right now in our clinics. So right now, moving to the summary, I think clinical AI adoption really depends on a lot of things, but what we have really seen is that it depends mainly on performance of the AI model, trust, ease of use, and return on investments. So in terms of performance, it really needs to be clinically validated. We can't just go on the results that are published by vendors. We need to validate it with our own data, test it, make sure it's working. In terms of trust, explainability is very key, and that's why we have seen a lot of success in models whereby, for example, segmentation, where it's shown directly to us, we know whether the output is trustable or not. One of the other barriers is in terms of ease of use. We actually had a failed deployment in terms of chest X-ray because the time to access the inference from the AI was too long. We report chest X-ray is very fast, less than a minute. If it takes us even 30 seconds to see the AI result, it's too long. So the results really need to be part of our clinical workflow for us to see them in use. Earlier on, they talked about whether or not the government is supporting AI use, and that's one of the biggest challenges we have right now. Who is actually paying for the AI models? It's actually quite challenging. For models that are come together with our machines, for example, the reconstruction is very easy. If they sell you the machine and the AI reconstruction is part of it, it's already paid for. But if you have to pay for your own models, it's very hard to make patients or even our chief financial officer pay for it. Finally, I would say that after we want to adopt an AI model, there are many reasons why we would like to see it deployed, but we have to bear in mind that there are a lot of ethical issues that we need to answer with AI in terms of the safety, the fairness, transparency, explainability, how robust it is, and of course, data security in terms of confidentiality and privacy. And in our institution, we implemented an AI governance model, which is risk-based. And we really are right now seeing that for applications that will impact patient care, we need to be very careful. And we right now are requiring that there are some manual control, or what we call human in the loop. We are actually sort of steering away from fully automated because we feel that there's a very high risk when it comes to AI applications in patient care. Whereas in the area of administration, we have actually allowed people to use a lot more AI because we feel that the risk to patients is low. And I think every institution that is doing AI implementation really needs to think about this today. So, sorry, I went a little bit over time, but I'll just summarize by saying that there's been a very rapid adoption of AI in healthcare across the board, and in particular in radiology and nuclear medicine. But we can't just take whatever results we see on the surface and say that these models are good. We really need to try out these models. We need to validate them. We need to test them and prove them in clinical workflows. And when we put in AI, we really need to generate value from our use cases. We can't simply do it because we feel like doing it or we think it's good, but we need to demonstrate what's the value. Are we really going to save time? Is the patient's experience going to be better? Are we going to save money? Finally, I'll just say that governance is a really, really key thing right now. As we move beyond the research space into clinical implementation, we need to be sure we don't cause harm to our patients. So thank you very much for your time and attention.